Welcome back to the WHY-O-MYO Podcast. This is Janine Steen, your host, hoping to answer your who, what, when, where, how, and why questions when it comes to myofunctional therapy. The last time we spoke, I was going over and reviewing some of the areas that are impacted by a tongue thrust, and therefore myofunctional therapy is the proper course of treatment, and that it's the best approach to treatment. But I realized that when I was listening back to the podcast that I really didn't go over what a tongue thrust actually is. So I want to backtrack before I continue and review the two areas that I didn't discuss the other day. And I just want to go back and discuss a little bit about what a tongue thrust is. I think most people, they do not know what to look for. They don't know what that means. But then once they see it and once they identify it, they can't stop seeing it and they can't stop identifying it. So the best way to really describe what a tongue thrust is to think about when you see a baby eating baby cereal or baby oatmeal for the first time. And when we try to put the spoon in the mouth with the food on it, more of the food winds up outside of the mouth and on their bib and their clothes and on their high chair than actually in their mouth. And you can actually see the tongue pushing forward and backwards as it pushes the food out instead of backwards towards the throat so that it can be swallowed and digested. And of course, the calories and the benefits and the vitamins that is necessary to be obtained. Well, that type of tongue thrust is very similar to what an adult tongue thrust would look like, or a non-infant tongue thrust, as there is a time that we all are tongue thrusters, and we all should be tongue thrusters. And that definitely happens during infancy, of course. And the research varies. Some people say to early toddlerhood, others say late toddlerhood. However, that tongue thrust should be completely extinguished. From a myofunctional therapist standpoint, obviously the second that child starts eating solid foods, we're looking and working to, at least preliminary, to get that tongue back in their mouth and limit the amount of times they're thrusting. That's also why we encourage infants, especially that have a more pronounced tongue thrust, or if they are worried about a tongue thrust, to stop bottle feeding at a year old and stop using a pacifier at a year old, or stop sucking habits at a year old. I can tell you from experience, and it goes way back to you have to practice what you preach, which of course I did not when it was my own child. But the older they get and the smarter they get, the more difficult it is to remove those items from their life, especially because now they can rationalize. I'll never forget trying to get rid of my daughter's binky. I cut holes in it, I threw it out the window, and for every hole, she'd come over and say, "Mommy, broken." And for every time she threw it out the window or we gave it to the garbage man, she'd wave goodbye, and then she'd say, "Uh-oh." Our worst attempt was taking her to Sesame Place and saying, "We're going to give it to Elmo so that he can share it with other little babies and boys and girls." And we did that. But the second we left the park and we were driving home from Pennsylvania in traffic, the second she was fussy, that binky went right back in. It wasn't until finally I said we were going to wrap it and leave it for Santa under the tree, and Santa would bring her a special present, that she actually gave it up. But in hindsight, I realized how horribly mean that was. And Jesus, I may have scared her for life considering what I did. Thankfully, it didn't happen. However, it was definitely harder and harder to do as we as she could rationalize and understand, all the things that I was not allowing for that item to be permanently gone. Obviously the same thing goes with thumb sucking and finger sucking and sucking on your hair and your blankies. All of those sucking habits, especially if they continue beyond 1 year of age, there's just more of a chance that it's going to perpetuate that tongue thrust, that infant thrust, beyond those toddler years, and have that adverse effect on those 4 areas that the 2 I went over last podcast and the 2 that I will go over in the next podcast. And those include, that tongue thrust may affect their speech, it may affect their diet or their feeding abilities, it may affect their teeth, it can affect their overall jaw, and now they're talking about how beneficial myofunctional therapy is for individuals with sleep apnea. So the strength that they're lacking or the weakness that they have could have an adverse effect on the collapsing of their airway and thus sleep apnea. So it's definitely multiple ways that tongue thrust can be affected, but I want everyone to have that visual of what it looks like by thinking of an infant. And there's a specific site here that I actually think is beneficial, and it really kind of brings everything together regarding what a tongue thrust does, what it looks like, and what it affects.
The normal swallow is not spectacular. The lips are together at rest with minimal activity. The mandible moves slightly upwards as the teeth contact. The tongue tip moves up against the premaxilla, followed by the body of the tongue. This creates the correct arch form and good dental alignment. There is minimal compression of the TM joint. The reverse swallow starts with the lips opened and much activity from the lower lip and mentalis area. The teeth are not together. Tongue tip moves down and forward between the teeth. The mandible is moved backwards during the reverse swallow. The tongue body moves down and away from the maxilla. The action of the tongue distorts the upper arch. The tongue moves between the anterior teeth, causing lower crowding and class 2 malocclusion. The TM joint is compressed as the condyle is moved back during each and every swallow. The mouth breather typically has the lips open most of the time. This makes the facial development narrow and long. The tongue tip pushes forward generally between the teeth, which do not contact during swallowing. There are many variations of this, but the elements are the same. The mandible moves back. The tongue action prevents correct arch development. A narrow V-shaped upper arch with crowding is the result. Typically, a Class 2 Division 1 with open bite is created by the action of the tongue. The backward movement of the mandible in swallowing compresses the TM joint, causing TMJ problems.
All right, I'm signing off, and we'll talk again soon.